Hello, welcome back. Last time we were looking at the mechanics of breathing, where we talked about uh, how physiologically it is possible for breathing in to occur and breathing out, which is inspiration and expiration. Okay. We talked about different pressures, how different pressures make it possible for these two mechanisms that account for the activity of breathing, okay, how it is possible for breathing in to occur. And we also established that breathing in is active while breathing out, which is inspiration and expiration. Expiration is passive as it is just due to elastic recoil that from the energy that was gained by the active process of inspiration. Okay. We also looked at the lung volumes and the capacities. So under those volumes and capacities, we established that those were the normal volumes, and we need to have those volumes attained for normal breathing to occur. Okay, for a person to have normal ventilation and normal gaseous exchange to occur, we need those volumes. So in an event of pathology, these are disturbed to the extent where these normal volumes can be reduced. And hence the interventions that come in cardiopulmonary, which we are going to be learning about throughout this course. So today we are looking at breathing exercises in the breathing concepts, okay? Also referred to as the ventilatory training. So this is simply, breathing exercises are simply designed, okay, to retrain the muscles of respiration and improve ventilation, lessen the work of breathing, and improve gaseous exchange and patient's overall function in ADL. So if you look at these are the same aims which we achieved when we are talking about the normal breathing. So in the in the case of pathology, these are compromised. Okay. So once they are compromised, it is your job as a physiotherapist to make sure that you retrain using these techniques that we'll be talking about to retrain the respiratory muscles so that you retrain ventilatory, the ventilatory organs so that you have these normal parameters back in place for the well-being of the patient. Depending on the patient's underlying pathology and impairment, exercises to improve ventilation are often combined with medication. Remember, you are not working in isolation. You are working with other multidisciplinary team members. So you find that this patient has been given some medication from the other team members. Yours should not be to substitute what others are doing. Okay, your activities should be complementary. So you work with what others are doing. You just improve, or you just add on the regimes which others are already doing, so that we improve the well-being of the patient. Air clearance uh, can also be, is also key, okay? It may be blocked, and one of your aims will be to clear it. You may also be, use some respiratory therapy devices, as well as a graded exercise program. Graded, we mean depending on the pathology of the patient. You cannot give a strenuous activity to a patient who's weak. So you're going to do a comprehensive assessment and assess the level of activity which your patient can tolerate. And that is how you're going to grade your intervention. Okay. Goals of breathing exercises and ventilatory muscle training include improving or redistributing ventilation. Remember, we talked about dead space ventilation last time. We also talked about alveolar space, alveolar ventilation. We said alveolar ventilation is very important and dead space ventilation has to be reduced. So all those in the case of pathology come into play. So your goal will be to improve or redistribute ventilation among many other goals that we're able to see here. Also, you aim to promote relaxation and relieve stress. At the end of the day, you are going to aid in bronchial hygiene. prevent accumulation of pulmonary secretions, as well as the mobilization of these secretions so that to improve the cough mechanism. And this patient should be able to cough up and spit out the sputum so that you unblock the airways, you unblock whatever has been accumulating in the airways so that you improve the gaseous, the area, the surface area for gaseous exchange. This gaseous exchange can be reduced by conditions such as most COPD conditions, chronic obstructive pulmonary conditions, as well as restrictive pulmonary conditions such as pneumonias. These can be indications for breathing exercises, as well as for relaxation. A patient would want to relax, and you can institute or train these exercises. Okay. After surgeries, they are also indicated for surgery. After surgery, we know the anesthesia has some kind of as an effect that reduces on the flow of secretions in the airway, which may lead to accumulation of secretions in the airway. So you train these exercises so that you push out the secretions. Okay. As you are planning to do these exercises, after you are done with your assessment, make sure you explain to the patient the aims and rationale of these exercises that you are treating them. Okay, let them understand how it will help them, the benefit and the procedure of how it is going to be done. Okay, put the patient in a comfortable position, relaxed position, loosened, loosened restrictive clothing so that they are free. Okay, you put them in the position known as the semi-forward position with the head and trunk elevated to about 45 degrees. Okay, and other positions can still come in as a way of progressing. You can put the patient in sitting, supine, standing, depending on how the patient responds and what the patient is able to tolerate. So this is the Fowler's position, semi-Fowler's position. Okay, you place your patient in that position, they feel relaxed as you teach them, as you retrain these exercises. Okay, you have to establish a baseline for assessing changes and progress. It is mandatory actually. Before you start treating the patient, you have to establish the baseline. You have to do a comprehensive assessment, well documented, so that you know the level where your patient is coming from. Okay, you know where the patient is coming from, and you can now know how you are progressing. Okay, so depending on the patient's underlying pathology and impairment, determine whether to emphasize on inspiratory or expiratory phase of ventilation. At that point where we shall be putting this into action, you should be able to know what is lacking, what condition the patient is going through. You demonstrate the procedure before you tell the patient to do so, so that at least they see it from you. Okay, some precautions, however, have to be taken into consideration. Okay, in that you should never allow a patient to force expiration. Okay, they should do it in a relaxed way. Forced expiration only increases turbulence of air, leading to bronchospasm and increased airway restriction. So we don't want this to happen. Do not allow a patient to take highly prolonged expiration. Okay, the patient's breathing pattern then often becomes irregular and inefficient if it is done in that way. It causes the patient to gasp and context with the next inspiration. So you want it to be smooth and rhythmical as it is normally done. Do not allow the patient to initiate inspiration with the accessory muscles of the upper chest. Okay, remember the primary muscle of inspiration is the diaphragm. So you do not encourage the patient to take an inspiration using accessory muscles. Allow the patient to perform deep breathing for only 3 or 4 inspirations and expirations at a time to avoid hyperventilation. Okay, some contraindications that come with this type of techniques are if the patient has increased intracranial pressure, unstable head or neck injury, recent spinal cord injury, impairment, or if they are taking anticoagulants, among other conditions. Okay, what if the patient have recently experienced a heart attack? Do not give them this training. Verify that the patient has not eaten for at least 1 hour or so. So it has to be 1 hour after they have eaten. Okay, and treated pneumothorax, they are contraindicated. Types of breathing exercises. There are what are known as breathing, diaphragmatic breathing, segmental breathing, pressed lip breathing, as well as sustained maximal breathing. Okay, so these are the common ones that that are usually done. So let's start dissecting each one of them. Diaphragmatic breathing. So when the diaphragm is functioning effectively, in its role as the primary muscle of inspiration, ventilation is efficient and oxygen consumption of the muscles of ventilation is low during relaxed tidal volume. So this is what you want, okay? You want the diaphragm to freely perform its function, okay? Although it controls breathing at an involuntary level, a patient with primary or secondary pulmonary dysfunction can be taught how to control breathing by optimal use of the diaphragm and decreased use of accessory muscles. So you find that these are possibilities when the patient loses their when there is some pathology that has set in their respiratory capacity. Okay. The goals of diaphragmatic breathing is that it reduces the work of breathing among many other goals. It eliminates the accessory muscles into activity. It increases the tidal volume, which is very important for ventilation, and it improves distribution of ventilation. So this is what you need to do. So this is very important. It also improves gaseous exchange and oxygenation. It is very important. You need this is what is physiologically done. So even as you are training, retraining the respiratory muscles in these type of exercises, your aim is to take them as back to their old normal physiological function, which is what we have described. So that is what should be at the back of your mind. Therefore, the procedure is that to prepare a patient in a relaxed and comfortable position. So mark this word. Every time, make sure that your patient is relaxed and comfortable, in which gravity assists the diaphragm to drain, such as the semi-Fowler's position. Okay, this diaphragmatic breathing enhances diaphragmatic descent during inspiration. You know, the diaphragm has to go down during inspiration. From its dome shape, it has to straighten up, and on expiration, it has to assume its original dome shape so that the air that is contained in the lung is completely pushed out. Physiotherapists assist diaphragmatic ascent by directing the patient to allow the abdomen to retract gradually during exhalation and contracting abdominal muscles. So you train your patient how these are done, how to ventilate, and how to do diaphragmatic breathing. The instruction will be, they breathe in, okay, inhalation, 2 breaths, you breathe in twice, pushing the air, okay, so as the air is going in, make sure that the belly is being pushed out, okay. The air is going in, make sure that the belly is pushed out. Then the opposite is happening in exhalation. Okay? Exhale, push out the air, and make sure that you contract the abdomen so that you push out all the air and you force the diaphragm to achieve its dome shape. By so doing, you are pushing air out completely, which is diaphragmatic breathing. So this same technique can be done in a position that the patient is comfortable with, depending on the progression. So if the patient is too weak, they can be lying in the semi-Fowler's position, which can be which can be improvised. It doesn't mean that you have to have that bed for you to achieve this position. What is important is the concept. At least raise the chest to somewhere around 45 to 60 degrees. Okay, once they are raised like that, then you can start doing the exercises. Tell your patients to put their hands actually on the abdomen and on the chest as they undertake these instructions. You tell them as you are breathing in, make sure the abdomen, you can feel the hand that is on the abdomen going up. And the opposite should happen when you are breathing in, when you're breathing out. Okay, so the patient can do this in either sitting, standing, lying, whichever position is comfortable. You can still do this as a physiotherapist by stimulating the patient by holding, using your hands on the chest area as well as on the abdomen, so that to tell the patient to breathe in and out. As they are breathing in and out, it should give them a feeling of pushing your hand up and drawing it in during expiration. By so doing, you are training the diaphragm. As you progress, you should want to add some weight to it so that you strengthen it. You know, the diaphragm is a muscle of inspiration. So the muscle, it means it can weaken or be strengthened. Okay, so you can strengthen it by adding some weight on the abdomen with the same instructions as we are able to see in that picture. The next type of breathing exercise is what is known as pressed lip breathing. So this is a strategy that involves lightly pressing the lips together during controlled exhalation. So this type of breathing technique is the one where you breathe in. You breathe in normally and deeply, then you breathe out with the lips pressed like you want to whistle. Or when singing, you want to make a high-pitched sound in singing, you press your lips and breathe out like that. Okay, so this is very important. It is indicated when you want to improve ventilation. Okay, this breathing pattern often is adopted spontaneously by patients with COPDs to deal with episodes of dyspnea. Okay, that is where it is indicated. It improves ventilation. Okay, releases trapped air from the lungs, relieves shortness of breath, and causes general relaxation at the end of the day. Okay, so this is another important position. Pressed lip breathing reduces hyperventilation, induced bronchoconstriction. Okay, and many physiotherapists believe that gentle pressed lip breathing and controlled expiration is a useful procedure, particularly to relieve dyspnea if it is performed appropriately. It is thought to keep airways open by creating back pressure in the airways. Studies therefore suggest that this type of breathing technique decreases the respiratory rate and the wake of breathing, thereby increasing the tidal volume and improving exercise tolerance, which is what you want to achieve. So the procedure is that you patient with your patient in a relaxed position. Okay, ask them to breathe in 2 seconds through the nose, keeping the mouth closed. Okay, and breathe out for about 4 seconds through the pressed lips. Okay, so 2 seconds in, 4 seconds out. Okay, so that you achieve what has been outlined already as benefits for this type of interventions. The next one is segmental breathing, which is performed on a segment of a line or section of the chest or that needs increased ventilation. So from your assessment, you are going to make a diagnosis. After you've made a diagnosis coupled with all the diagnostic procedures that we do, which includes auscultation, you are going to notice that the area that needs, remember the lung is made or is divided in what are known as lobes plus other types of division. So you may discover that maybe it's just one lobe which needs aeration or which needs increased ventilation. So you are going to do what is referred to as segmental breathing. Okay, it is used in conditions such as post-thoracotomy, okay, trauma to the chest wall, pneumonia, mastectomy, post-mastectomy scars, post-chest radiation fibrosis. So from your assessment, you are going to at least come up with one of those. Then know that what you want to do is what is referred to as segmental breathing. It has advantages in that it prevents the accumulation of pleural fluid. It prevents accumulation of secretions. It also decreases paradoxical breathing as well as the panic. It improves the chest mobility as well. So depending on where you have uh, found the problem, the instructions are similar to the ones in diaphragmatic breathing. You hold the part that you are concerned with and let the patient breathe in, trying to push your hand up from the part that you are breathing. I mean, you have held. Okay, you can progress by compressing. Make sure you compress so that the patient also adds a little bit of energy or force to push your hand away from the part that you are treating. You can also do that on any part that you have diagnosed, including the posterior basal line. Okay, you can do this. The procedure remains the same. The patient can still do this also on their own. You can teach them. They can use some kind of a cloth around their chest, tie it, and when they are breathing in, let them breathe against the force of that cloth. And when breathing out, this cloth should be tied so that it helps to push the lung up. Okay, I mean to push to recoil the diaphragm. You push out the air. Then breathing in should be against that same amount of force. So that again can happen on any of the lobes of the lungs. Just check the lung that you want to work on and do the same. The procedure is the same as the ones that we have already highlighted up there. Okay, so these are some of the positions in which you can do this, but the instructions still remain the same. Let the patient feel that you are pushing them, let them feel that they are pushing your hand away uh, from where, the part that you have held. The other one is known as glossopharyngeal breathing. You know, glosso means the tongue. Pharyngeal, pharynx, or those that have to do with okay. So the pharyngeal and the pharynx, we know what they are in anatomically. Okay. So glossopharyngeal breathing is the means of increasing a patient's inspiratory capacity when there is severe weakness of the muscle in inspiration. This is a technique that is performed by using muscles of the mouth, cheek, soft palate. So basically what we're trying to say is that this is the kind of exercise where the breathing in is done by way of protruding the tongue. Let me use the word protruding. You push the tongue up and backwards. So as the patient is breathing in, they are like trying to push air in using the tongue. Okay, they'll push air in 1, 2, 3. Okay, then breathe out. So glossopharyngeal breathing involves taking several gasps of air, usually 6 to 10 gasps in a series, to pull in air into the lungs when the action of inspiration muscles is inadequate. So this is just a technique where this person breathes in, gasps for air with protruding tongue out. So it keeps on protruding the tongue out, in and out as a way of trying to gasp for air. Then it compresses the air in. When they breathe in, they have to close their mouth and make sure they push the air inside so that it fully strengthens the diaphragm and it fully fills in the inspiratory capacities of the muscle. Okay, then you breathe out. That is what is referred to as glossopharyngeal breathing. Okay. So among us, the normal mechanism of breathing, coughing is very important. Okay. It's very important to eliminate respiratory obstructions and keep the lungs clear. Airway clearance is important part of management of patients with acute or chronic respiratory conditions. Coughing is usually a reflexive activity, and the following are the series of events during a normal cough. Number one, it calls for deep breathing. Okay, in a reflex activity, you are going to breathe in deeply, the glottis closes, vocal cords tighten, abdominal muscles contract, the diaphragm elevates, causing an increase in intra-abdominal and intrathoracic pressures. Then the glottis suddenly opens and the explosive expiration of air occurs. Okay, so this is what is referred to as the normal coughing. But this coughing mechanism again, it can be lost. Okay, it can be lost due to the pathologies that may have inflicted the respiratory system, including the same respiration, COPDs, chronic obstructive pulmonary diseases, as well as restrictive conditions that we earlier talked about. Okay, so the effective cough, the effectiveness of the cough mechanism can be compromised for a number of reasons, which include decreased inspiratory capacity, inability to forcibly expel the air, okay, decreased inspiratory capacity due to pain, okay, rib fracture in restrictive conditions, okay, also can be due to spinal cord injuries. It can also be due to decreased action of the cilia in the bronchial tree, which we are going to find in most of the COPDs as pathologies in the COPDs. Increase when there is an increase in the amount of secretions, which can also happen in conditions that are under the COPDs, and as well as in restrictive conditions such as cystic fibrosis, chronic bronchitis, and pneumonia that can result. So it is a very important technique that should be taught if it is lost by those pathologies. Okay, you have to assess before you start teaching. You have to assess the patient's voluntary or reflective cough. Teach the patients controlled diaphragmatic breathing and emphasizing on deep breathing. We have already talked about diaphragmatic breathing. So you tell the patient how it is retrained is that you instruct your patient to breathe in. Okay, breathe in deeply and breathe out. Okay, breathe out to the extent where all the air goes out. They feel that all the air goes out. Then towards the end, let them push out the air forcibly as though they are trying to clean the glasses. The way we push out air when we're trying to clean the glasses. The glasses, the ones we wear. They're trying to clean the glasses, then you push out the air. There's so that kind of sound at the end of expiration will trigger some reflexes, which will trigger the cough reflex. At the end of the day, the cough reflex will be the coughing will resume, and that is referred to as a half. After breathing out completely from a normal breathing in, breathing out completely, then a half at the end of the day, even at the end of the expiration, even actually pronouncing the word half at the end of expiration. When they breathe out at the end of expiration, let them pronounce the word half. So as they are trying to do that, a cough reflex may be triggered and they may cough up, which is very important. Okay, so this is what we had in this discussion on in this presentation on the concept of breathing. All right, thank you so much. See you in the next presentation.